Now you can simply pause the video and you can try to find out where is the problem. Where? Now this is the CT scan of the brain because we can very nicely see the skull. This is all skull. This dense white radio dense skull which is only seen on CT scan. Now this patient presented with convulsions and when the CT scan was done, this was found. Now when you zoom in, you can try to find out the problem and you can see some very hyperdense small circular lesions like this. So these are seen in the parenchyma. You can see this. So this is 1, this is 2, this is 3, this is 4, this is 5 because this is on the right side, this is left side. So there are around 5 such lesions. This and this are same. Apart from that, this one is 6th, this is the same 6th, this is 7th. So there are 7 small lesions. This is 8th, this is a very small 9. Now this is 10, very small lesion which is 10. This is 11, very small lesion 12. So when we see this 13, there are very small radio dense white lesions, and this type of very small lesions which are less than 2 centimeter and multiple lesions almost always suggest NCC, that is neurocysticercosis. It is always suggests neurocysticercosis, and it can give you a starry sky appearance. Starry sky means you will see so many stars or so many calcified lesions in the brain. Such lesions can be in hundreds and thousands as well. There can be numerous lesions, numerous small, dense white lesions. So these are more of a calcified lesions because these are appearing dense white. Now we must know these are the ventricles. These are the ventricles. And this is a typical ventricular calcification. This is not a neurocysticercosis lesion. This is inside the ventricle, and these are the choroid plexus. Choroid plexus, which synthesizes CSF. The function of the choroid plexus is to synthesize the CSF, and there is calcification inside seen. This is choroid plexus calcification and not a neurocysticercosis. And this is a pineal gland calcification. This is pineal gland which is seen situated in the midline. So uh, I want to tell one more thing, whether this is a neurocysticercosis or not. Now, if you are confused whether this is a neurocysticercosis lesion or not, you can simply trace the same lesion in the other scans, like here. So here you can see it, here you can see it, and above that also you can see it. So it is in here. So this is more of a continuation of bone, and it is not a calcified lesion because you can see the NCC lesions are almost always perfectly circular. They are mostly circular and small lesion. Most common competitor or confusional part with NCC is tuberculoma. Now, how to differentiate? NCC, they are almost always less than 2 centimeter. Tuberculoma, they are usually more than 2 centimeter. In NCC, there is no much edema. There is no edema. But with tuberculoma, there is usually always a marked edema nearby the lesions. The tuberculoma lesions, they are usually very few. There are usually few lesions, whereas in NCC, there can be hundreds and thousands of such lesions. There can be numerous lesions. These few regions of tuberculoma usually conglomerate. So one large lesion, they usually fuse and form a large lesion with edema around. Whereas in NCC, there is no conglomeration of such lesions. One other things which we must remember is, as we know, this NCC is called by the tinea infection, which actually occurs because of the eating uncooked pork or uncooked beef. So this NCC is caused by the eating uncooked pork or beef. So uh, the thing is, in the NCC there can be numerous lesions, and it is usually the treatment is available for this NCC where you have to give the albendazole, usually 400 milligram for almost up to 30 days. And once we start this treatment, because of the damage to the cystole, because of the damage to this tinea lesion, it can cause edema around. This edema may increase after starting the treatment. So we always give steroids whenever we start with NCC. So we give steroids at around 8 milligram thrice a day for around 10 to 14 days, and then we taper it over a period of 1 to 1.5 months, depending on the lesion, depending on the edema, depending on the response. One more thing for this NCC is we can see different morphologies of NCC lesions. What do I mean by that different morphologies? Is the lesions may be completely calcified like this. This is completely calcified lesion. You can see a ring-like structure, or you can see a ring-like structure with head or scolex. Now, what is scolex? Scolex is the head of this NCC larva that you can see, and this is almost eccentrically placed. This is not placed in center. This is always placed in the periphery of the ring lesion. So you can see this calcified granuloma, calcification, you can see that as a ring, or you can see that as a scolex. So these different types of morphological lesions can be seen with NCC. So this was a very interesting CT scan of the brain showing multiple small hyperdense calcified lesions suggestive of the NCC, that is neurocysticercosis. Thank you.